Our next presenter is Dr. Christopher Doumas. Is one of our upper extremity surgeons. He's also an associate professor in our orthopedic department. He's going to talk to us about the use of biologics with the shoulder.
So talking about biologics in the shoulder, this should be the greatest what's going to be going on in the future. We'll see whether that pans out or not, though. I mean, so disclosures, we're talking a lot about rotator cuff tears. A lot of people, you probably know, have one. Some of you may have had one. The question is really what's the best way for these, whether they need surgery or not is one of the questions that Dr. Monica brought up. But really, what do the biologics offer shoulder surgery at this day and age? Is there any evidence that they make shoulder surgery better? And that's really the question as of right now. And this may change as time goes on. So really the question is why do we want biologics? Why did this come into play? So if you look at the reported rotator cuff repair literature, it ranges anywhere from a re-tear rates from anywhere from 20% up to 90% in specific types of rotator cuff tears. This depends on a lot of different things, whether it's the timing when you fix it, how far out they are, the location, the size of the tear, the tendons that are involved, the age of the patient, obviously medical comorbidities, and the chronicity. So there's a lot of different factors that do come into play, and that can affect that range in a ridiculously large way, as you can see. So typically the way you look at these things is if it's an early failed repair. Well, what's the reason for that? It's typically a poor construct. We're talking about fixation techniques, suture anchors, suture techniques, tissue quality, things of that nature. But if you're talking about late failed repairs that hold up for the 6 weeks or so and they actually look like they're intact on MRIs, ultrasounds, you're really looking at poor biology. And so that's really the focus here is how do you make better biology? Anybody can get the tendon back to the bone, but who can actually make it heal more reliably or quicker? And so these are sort of the races that some of the companies are going against. One of the things that you'll learn, or I'll talk about a little bit, is that the finances involved in this. Is the companies that are doing these types of things and making these products, it costs anywhere from $30 to $50 million to actually get these things off the ground. So there's not a lot of companies that work on these things, and it's a very big nut to put out there. You're talking about chronic rotator cuff tears, very different than acute ones. They typically retract. They may be very large. They're difficult to repair and get back to the bone. And they reliably progress with atrophy to the muscle belly. They don't always get that high riding humeral head that we talk about with rotator cuff arthropathy. Some of them do not. Some of them compensate very well. I'm sure every single one of the guys over here, would ask the question, in some patients, they've got massive rotator cuff tears that just sit there and they take their arm and they go up like that, like they have. So the question is, does it really matter if the rotator cuff heals as well? So in a big meta-analysis, over 800 patients, they looked at patients who had rotator cuff repairs. And so the ones who were most satisfied were the ones that had the most strength. And so the ones who had healed typically had the most strength and had a strong shoulder is really a happy shoulder. And so that's looking at all age groups. This included older patients as well. Again, 78% healed. They had a 21% re-tear rate. So it's a pretty significant re-tear rate when you're talking about 860 patients. I'm not sure what rates everybody has here individually, but for me, if I had a 1 in 5 out of every cuff that I fixed that didn't, pretty disappointed with that result. So how can we improve that tendon-bone interface? All right, it's all about histology. It's all about tendon quality. So you've got different patches that are out there that help promote the material properties of the repair, and you've got growth factors, which is a huge area of interest, that promote the structural properties of the fixation. The different types of patches that you have that are out there are allografts, xenografts, synthetics. People use a lot of dermal allograft tissue. Some of the synthetics are showing a little bit more promise as time goes on in some of the studies, which I'll go into. There's a lot of preclinical work out there, basic science research looking at these things. And those are much cheaper studies to do, obviously, as opposed to a full clinical trial. And there's a lot of things based on dogs and rats and things like that, doing tendon model healing, looking at the histology, looking at the strength and the biomechanical properties of this. So there's a lot of preclinical patches out, studies out there for both growth factors and for patches. The question is does it actually translate forward into human use? So what are some of the indications? Younger patients, potentially, people who are failures or at risk for failure of these surgeries, chronic massive tears, and chronic changes, because when you have a chronic rotator cuff tear, you get this fatty atrophy in the muscle belly because that tendon has not been attached to the bone for such a long time. The muscle's not working and it gets replaced with fat. Salvage cases. So some contraindications to this include rotator cuff arthropathy, pseudoparalysis of the shoulder, irreparable tears, and that could be debatable on who wants to call that what, and really unrealistic expectations. And so, if you tell your patient you're going to be using, growth factors and patches, and we're going to cover this hole really, really well, they think they're going to have a 20-year-old shoulder by the time you're done with this case. Sign me up. It's great. I'll take a 20-year-old shoulder also at this stage of the game. But it's not going to happen. And I think that's one of the main things is about what's realistic. There was one patient in particular, it was an IME that was done that the guy recommended on a chronic recurrent tear. We fix it with, PE and patches and everything like that. And, I had to kind of go back and explain to the case manager or the patient that this isn't the latest and greatest as to what's going on out there right now. So is it really necessary? There's a lot of evidence out there that's been gathered over the past 10 years or so. A lot of it is level 4 evidence. There's not a lot of strong literature that's out there looking at these types of results. And there's a lot of different types of patches, and there's a lot of different types of growth factors. So just sort of starting with some of the patch work, if you're looking at some of these long-term successful arthroscopic repairs, this is a study, it's a level 4 with large and massive cuff tears using one type of patch. And it showed that they had successful repair of these large tears in 83% at 12 months and 78% at 42 months. So it's pretty darn good. And they had substantial functional improvement. And so this is just a picture of the inlay graft on top of the tendon, so you get an idea. There's another study, again, looking at 12 months follow-up, showing that the patch was well tolerated, it had good clinical efficacy, it's 10% re-tear rate at the 12-month time point. Again, very good results. Different types of patches are available. This is one with a xenograft. Again, level 4 evidence only, showing that there was improved functional outcomes and strength. So there's a lot of these level 4 and basic science literature that is out there. And a lot of these will demonstrate significant improvements in pain. This one, again, that was done in 2012. Again, level 4 evidence. And they had showed these improvements continued for up to 3 years. All right. So maybe there's some success with these patches that's going on. Problem is it's level 4 evidence. So, looking at different types of patches also makes a difference. And so this is a very good, a little bit better level 3 evidence. Back in 2014, looking at a synthetic patch compared to a control group and compared to a collagen patch. And they did well. The synthetic group did very well over the 36-month outcome. And if you look at the re-tear rates again, they were still pretty significantly high. The control group 40%, the collagen patch 50%, and then the polypropylene is 17%. So the question is synthetics really the future of doing this? Do you need something that's going to stick around? Because the whole goal with these is the tenocytes invading into these other matrices and actually giving you normal tendon back. You're just replacing the scaffolding basically. So you might need something more permanent. I think that's really, at least this is one of those papers that's sort of showing that synthetics might really be the answer to the future. So what about growth factors? Everybody knows about PRP, it's supposed to solve everything. Tiger Woods get it, had to go to Canada for it because they don't have it in the States apparently. Stem cells are everywhere. They're being injected into knees for arthritis and whatnot. So really, what are we doing and what are we looking at with these things? So PRP is a very common thing that's out there. It's a relatively simple procedure to go through, but there's a lot of different ways of using it. And that could be a whole talk on its own. But you're looking at really taking away some of that platelet-rich layer of the blood after it gets spun down. And that layer has of growth factors that are in it. All right? And so you utilize some of those to see if they can help stimulate some response. One of the things to keep in mind as physicians when you're doing these things, and if you're looking at it for yourselves or a family member, is you're really looking at some of these. If people are doing it, you want something with a low white blood cell level concentration, not just a high platelet level. So the white blood cells actually can have a degrading effect on the outcomes with these studies. So what do they do clinically? All right, again, there's a lot of basic science research that's out there. It shows that it can stimulate things. It works in other areas of the body and specific things that have been proven, to some extent. But you're really looking at that, this was in 2013, looking at basic science research that these tenocytes can be stimulated by platelet-released growth factors. So it works in the lab. How does it work in a shoulder? One of the things you got to keep in mind with all these things is the half-life. And so that's just how long this thing is going to stick around in a shoulder. It's not that long, and so you have to keep these things in mind. So you're talking about 2 minutes, 14 hours, 2.5 hours, things of that nature, that some of these factors are going to be sitting around. How much of an effect clinically is that going to have on my patient? What is the cost involved in using this? Are these things clinically relevant to healing? Where does it go? So you can do it either on top of the tendon, which is liquid PRP, and again, it's gone in about 7 to 12 hours. You can get it mixed with a fibrin matrix, like a fibrin glue type matrix. People usually put that between the tendon and the bone, and that slowly gets released over the course of 7 days. You can have it next to the tendon, so there's cheaper options available. Stephen Snyder developed this, or popularized the crimson duvet technique, where if you look on the bottom right, there are these little poke holes, fenestrations in the greater tuberosity. You turn your scope water off, and this blood will just sort of bathe over the rotator cuff repair. There's growth factors in that. Again, it's all coming from the bone marrow, so there's factors there as well. It's a little bit of a simpler, cheaper option, obviously, because there's no development cost involved in that. So when you look at PRP with fibrin matrix now, all right? So this should potentially be better than just squirting some liquid in there and having it wash away from your repair, or come out with a suction or ooze from the wound. Basically, these are a couple of good studies that are done level 2, and there'll be a level 1 that comes up next. And these are actually on the AOS website when you talk about PRP and you're talking about growth factors from rotator cuff repairs. Not as a warning, but almost as a warning, where this is what they have a little article on the 2 doctors that did these studies talking about these things and the evidence. And so basically, level 2 studies show that there's really no demonstrable effect on tendon healing, vascularity, strength, and clinical rating scales. And it actually may have a negative impact on healing. And so, they still said there's further studies that need to be done and everything like that, but these things are not sort of the next, there's no magic bullet right here. So a controlled randomized clinical trial, level 1 evidence, did not also, again, support the use of autologous PRP with fibrin matrix for augmenting the repairs. This looked at small and medium repairs, all right? So I think one of the things to take away from this is that these are small, medium tears. They usually do pretty well. There's a relatively lower re-tear rate. Does this translate over to some of the larger massive tears? So that's one of the questions that they brought up. There may be a role for it in a more chronic tear. There may be a role for it in a massive rotator cuff tear. It just hasn't been done yet. And it's possible that other preparations of the PRP, this looks at one preparation technique of this, you don't know what that compares to other techniques. And so, there's a lot more to go when you're looking at PRP and rotator cuffs. So when you have somebody as a physician saying, oh, this is what I would do, this is what I would do, you have to question some of those, the thought process as far as, whether that's going to work or not. So some of the strategies in basically recreating some of these healing rates in a review, this is in CORE in 2010. It basically showed that they don't really have any conclusive answers. And so that's really the whole premise of my talk, is there's no conclusive answers. You can talk about debating back and forth whether you want a first-time dislocator or this or that, but there's really no answer right now as to what's going to work with these patients, how they're going to work, and in what manner they're going to help benefit them. So they are established in other fields. They will probably potentially have a role in orthopedics going forward, and specifically in rotator cuff repairs going forward, but it's very inconclusive at this point. And I don't know if anybody here does it, but I routinely don't use these things. I've considered using them for patches for chronic tears. I have not used the growth factors, but for a patch, for a chronic massive tear that has some atrophy, things like that, it's a possibility. But again, the main thing that you talk about with these patients is the clinical expectations. And if the patient has unrealistic expectations, then no matter what you do, it's not going to work. They're not going to be happy. So I just thought this was a great slide because it really goes through some of the differences between liquid PRP and using the solid fibrin matrix PRP. And if you actually break down the studies on these things, you look at the ones that had some benefit to it, because there's a ton of studies that show that it doesn't work. There's a ton of studies that show that they do work. And so if you actually fragment these out, the ones that have the liquid PRP seem to be a little bit worse. The solid PRPs tend to have better results that go along with their clinical trials. And so again, what's the cheaper option? I mean, one of the things that we're all under pressure for now is reducing costs in the healthcare system, and trying to save money for this, that, and the other thing with different anchor, different suture techniques for fixing rotator cuffs. Cheap option is a crimson duvet technique. You're basically doing multiple channeling in that greater tuberosity, and it has been shown to decrease the re-tear rate after arthroscopic repair. The flip side of that is you're also weakening some of the greater tuberosity out there. Does that potentially weaken the anchors in some patients? So it has to be carefully done. It's got to be well controlled where you're putting these these little holes in the bone to try to make sure that you're not weakening your actual structural construct. And so some of that also may change the way you do your therapy. Now, what it didn't show is significant difference in the clinical outcomes between these two groups. Okay, but if they've got better or lower re-tear rates, you would assume that long term, eventually, these would potentially have better outcomes and show some better clinical outcomes. So again, bone marrow stimulation, this was in 2015, just last year, to the footprint with a repair, improved cuff integrity, even in large and massive tears. So it's a very cheap way of helping to treat these rotator cuff tears and try to increase some of that biology to get better healing rates. So there's also obviously combinations you can do. This was just released in April of this year, looking at concomitant bone marrow stimulation with a patch, and it significantly reduced their re-tear rates and their medial row failure rates again. This was massive rotator cuff tears. So again, most likely as the future goes, I think one of the things that we're going to be changing is more those large and massive rotator cuff tear patient population groups with some of these biologics, because the ones who have small and medium, you're probably not going to see much of a difference between using a growth factor, using a patch, and not using it. Again, that's just anecdotal on my part. Another one, acromioplasty. This has been very well debated over the past few years in rotator cuff surgery. Do we do an acromioplasty? Do we not need to do an acromioplasty with our standard rotator cuffs? I mean, when I trained, this is all we did, acromioplasty, acromioplasty. We had some papers that came out and said you don't need them for rotator cuff repairs from an impingement standpoint. We always get worried, well, is that going to impinge on my repair? So it probably does not much to do with that, but are you losing a source of healing through not doing it? And so I still routinely do mine. I don't know about the other guys, but I think most people probably still do. It does increase the concentrations of several growth factors in the subacromial space. So again, you're just looking for bleeding tissue. You're looking for this bone marrow. You're looking for the blood contents that helps bring healing. It's like when we talk about AVN or avascular necrosis of the hips and wrists and things like that, you're trying to bring blood flow to the area to get healing. And it's very similar in this regard. So I think there's still a huge role in acromioplasties with rotator cuff repair. And again, it's a cheap option to get some biology in your shoulders. One, I think, the most interesting areas that's to come out in the future, and this was won the Near Award, I think it was in 2013, this was published in 14, is using adipose-derived stem cells and using some stem cells for certain techniques and trying to improve the biology. So again, this is a rabbit-based model, so it's not a human trial or anything like that at this point. But I think the slides are pretty dramatic when you look at this, as far as if you look on the left, you're looking at the stem cell use plus a surgical repair. And you can see it looks like real good tissue. You're not seeing a lot of white. The white is the fat. You're looking on the right, that's the control group. That's really what the normal structure looks like. Relatively similar, okay? If you look second from the right, you're looking at, with just saline alone, you're not looking at anything. So that's when you don't do anything. You get this big amount of fatty atrophy that goes in. There's no repair done. You get this fatty atrophy of the muscle belly. When you look at just the stem cell alone, again, a little bit more cells, but you still have a lot of fat. And if you look second left, where you get the saline and the repair, you still see there's quite a bit of atrophy there. So if we can reverse some of these muscular changes that we're seeing in some of these more chronic retracted tears that have this grade 2, grade 3, grade 4 even muscle atrophy, then that is a game changer. And so this is where I think a lot of people are a little bit more excited about for the future. Whether it pans out into some of those human studies, it remains to be seen. So really the main take-home messages here are that preclinical trials don't always translate to good results. I mean, you're talking about rabbits and rats and dogs, and they don't really always translate over, and that's been proven throughout the years with orthopedics. Patches are gaining traction, but techniques, cost, and reimbursements are problems because we don't have a way of charging for the extra time that's reliable for putting them in. The costs are not necessarily contained, and they get translated out to other payers. And synthetic and permanent, is that really going to be the main future for some of these? What's the role? Is it going to be the small tears, all the tears, or just those chronic retracted tears? And liquid PRP may be effective. I'm not going to say it's not, because it has been shown to work in some studies, but really the solid PRP with the fibrin matrix does seem to give better healing rates. But marrow stimulation techniques are low cost and can be very, very effective, and they're available to us every day that we do these. Bone marrow aspirates have shown very little evidence at this point. And then really the question mark is going to be, where do stem cells play a role? All of these going through, there's minimal evidence that's present as far as dosage is concerned, the timing, the frequency, how they're manufactured. And so there's a huge difference that comes into play with all these different types of growth factors and patches that we're looking at. So, once we find something that works, then maybe we can hammer out some of these other things that need to be done. But again, most of these clinical trials, from a company standpoint, it costs about $30 to $50 million. So there's very, very difficult products to develop financially in the whim of a hope that this is going to work and make tendon healing better. Thank you.
Any questions for Dr. Doumas?
Yeah, the question was related to the PRP. I know you focused on the PRP using intraoperatively for the repair, but do you have knowledge or evidence of the use of PRP for non-operative to prevent the repair?
Yeah, well, I didn't want to get into all that because there's just a ton of different things that are out there. So again, I think it's very similar to other areas in medicine. There's going to be studies that show that it shows some increased benefit from a clinical standpoint, but there's no consensus as to whether these things work. And really that's what it comes down to. And it basically translates over to the repair models as well, is that there's really no evidence that's out there that's going to basically convince anybody from a level 1 standpoint that this is necessary, this is going to heal a partial tear, things like that, you know. And I think it's a dangerous slope to go on because, again, when you use one technique, then everybody's they're going to develop the other ones. And they say, well, this works just as good as this, but there's no studies comparing them. So
yeah, I think nothing is absolute. I do PRP for non-operatively, and even on the American Academy of Orthopedic Surgeons site, there's some studies from 2013 showing that the use of PRP, you know, injection-wise, liquid form, can actually help decrease the number of surgeries that are needed down the line. But again, there's insurances don't always cover it, and there's more out-of-pocket expense, but it is something that does seem to be possible to avoid these surgeries.
And I think some of the things that you have to keep in mind when looking at those is I've done it for elbows, for tennis elbow. You know, I see a ton of tennis elbow in the office, and I've done it for that before. People have injected Botox into tennis elbow to try and get it to do well. I do something different at this point as well that I seem to like now, which I won't get into. But, you know, you're looking at things that if you're affecting, are you really affecting the natural history with it? I think that's really the main question that's hard to control with these situations is, sure, you can create a paper with evidence. There's whatever level it happens to be. But there's a huge amount of pressure for publishing in the academic world, as we all know. There's a lot of failable studies that are out there that have been very well reported, just, you know, starting with autism, but I'm not going to get into that debate right now either. But you have to just read the studies and take everything you read with a grain of salt. And that's really the way I look at these things, is find out who's financially motivated to do it, who's academically motivated to do it, you know, and it's just, those are the things you have to look at.
For your chronic massive rotator cuff tears, would it be beneficial to try the PRP before doing the patch, or is a patch just the way to go for that? Well,
if you're going to be talking about doing chronic massive repairs, I mean, you're talking about just repairing these things. You know, for example, I just had a woman in the office this week. You know, she'd been ignored for years from somebody who was treating her with just repetitive injections with steroids. And for those types of patients, what I typically will do is have things available. You know, so I'll have a patch available if I can't bring the tendon back over. You know, I'm still a big proponent of doing arthroscopic releases, doing an all arthroscopic repair. It's much quicker, it's much easier to do these open, and if you're going to be doing a patch, then I'll open them up because you can do them much easier through a mini open incision. So for example, for her, when she gets on the schedule, if she does, you know, we've kind of went over, she's thinking about everything that we just talked about as far as re-tear rates and things like that. But she's somebody who's relatively well compensated. She hikes her shoulder up, but she can actually get up 170 degrees. And so the question is she's 55, that's different than a 70-year-old with the same problem, because a 70-year-old, great, we'll let you go at some point. If you develop the rotator cuff, then we can do a reverse replacement or something along those lines if you need it. But for a 50-year-old, are you trying to save their shoulder from needing that replacement down the line? So what I'll do is I'll basically have everything in the room, and we'll go in and see if I can get it back over. If I can get it back over easily and bring that tendon back after doing some releases, then sometimes I won't even put anything in, but I like to have a patch around in case it's difficult to bring it back. And if it's difficult to bring it back, then I like to have that extra structural reinforcement for sutures and just to potentially have a thicker tendon, you know, that's anchored to the bone. If you know you can't, then there's other techniques coming out now for chronic retracted tears, like a superior capsule reconstruction, that you still can use the patch for, that you can recreate a ligament from the glenoid to the greater tuberosity. So in that case, again, you can still do that different procedure by having those, you know, items available. So, but there's no, I don't want to get into that because there's not a whole lot of literature on that yet. So.